Are we ready? Good morning, everyone, and welcome to the third quarter North Carolina Population Health Collaborative meeting. We are so very pleased to have you join us this morning. We know how busy everyone is, and we're glad that you're here for what we hope is a very intriguing and exciting conversation. Our panel discussion today is on a very important and a timely topic. We are pleased to host this discussion on using real data to drive equitable outcomes, and would like to give a special thanks to the Duke-Margolis Center for Health Policy for their partnership with both the North Carolina Medical Society and NCHA in coordinating today's panel discussion. So I think we're in for a treat. In an effort to keep the discussion going and to capture all of your questions, we would like to invite you to send any questions and feedback you have through the chat function. We will have someone monitoring the chat function, so we'll do our best to make sure that we answer your questions in real time. Additionally, as with most other panels, we would ask that everybody place themselves on mute in order to allow for the best discussion experience. We thought that in order to set the stage for our discussion today, that we would have Tatiana Kelly provide an overview on efforts that have been made to date on both a national and state level in this area. Tatiana is the Vice President of Planning and Strategy and Member Services at the North Carolina Healthcare Association. She's been leading strategic planning and deployment efforts at NCHA for over 3 years. Prior to joining NCHA, she was a Kaiser Permanente of Georgia for 13 years in a variety of roles. She holds a master's degree from the University of Texas at Austin and a bachelor's degree from Center College in Danville, Kentucky. And so I'm going to turn it over to Tatiana to start us off today on this very, very important discussion.
Good morning, everybody. I'm Tatiana Kelly, as Ruth said, and I'm so glad to help facilitate the beginning of this conversation. As we were putting together this meeting, one of the things that we wanted to provide context for is some of the efforts that we've all been recently involved in, as well as providing some of the context for how long these types of efforts have been going on. So for those of you new to healthcare, this is something that we've been grappling with for decades, as it were. And I also just want to set the stage for why this is important. So if you are not aware, the Commonwealth Fund, which is one of the many groups that are heavily involved in understanding the role of not only data within looking at our healthcare system from an equitable lens, but also the application of data and what measures folks use. One of the things that they have noted is that the rate of preventable deaths is almost twice as high for Black North Carolinians as it is for white North Carolinians. So if we have no other call to action, it is this. So what I'm going to go through today in this brief presentation is some of the history, some key highlights with what's happening on a national front, not only with Medicare, but also just with groups that operate nationally. And then what's a brief overview of what's happening within Medicaid and other statewide efforts and common themes, and then where we think we can go from here. As we have our panel discussion, we're going to be asking our panelists some important questions about these theme areas and hearing from the experts where they think some common ground is and how we can make a difference. So obviously we've known about this forever. So really dating to World War II. And as I did some research, it's been kind of interesting to see that how the ending of World War II and some of the horrific events that happened during the war, especially in Germany, really led to looking at the inequities that exist within all systems. And so as we move forward into the civil rights era, you see an increased focus on inequities in healthcare, particularly for Black Americans. And then you see on a world stage, folks really start to get engaged. Margaret Whitehead's 1991 report was viewed as one of the most seminal events. And then you see in 2000, the Minority Health and Health Disparities Research and Education Department get formed. So the real data elements that Medicare are requiring date back more than 20 years. And then the call to action from NCDHHS is also from the early 2000s. So this is not something new. Obviously, there's a lot more focus in recent years, somewhat owing to the events surrounding the death of George Floyd and recent civil unrest, but also just a call to action that this has been going on for way too long for us to allow this to continue. So as we look at what some of the things that Medicare is proposing to do, I think what's really causing us to sit up and take some notice is that the 2021 proposed rules for inpatient, outpatient, and physician all contain within them some equity measures that they're looking to make sure that we're all commonly collecting for Medicare patients. And also they are looking to aggregate data across all populations that constitute Medicare service areas. So there's an increased commitment from Medicare, and there's also a really concerted effort on their part to be able to provide back meaningful information to providers on where those disparities are. Obviously, there's some interesting thoughts there that I'm not sure everyone always agrees with. But what we'll do as we send these slides out, I have links to all of the proposed rules in the notes of these slides. So we'll be happy to share all of those so that everybody can get firsthand information on some of the proposals there. Also, on a national scale, there are many, many groups, not only the Commonwealth Fund with their measures and dashboards that you may be familiar with, but historically, the Healthy People 2010 and beyond. So this report that was really seminal in understanding where we all stand and what the baseline is that we're hoping to make improvements on. Those reports have been coming out since 2010 or since 2000, looking forward in 10-year increments. Then you also have groups like the National Institute of Minority Health and Disparities and the Institute for Healthcare Improvement, Robert Wood Johnson, the AHA, AMA, and many, many others. So again, I've got links in the notes of these slides to sort of point you back to many of these groups' works. Also, Kelly, and I would not even pretend to be able to speak for Kelly, but Kelly's going to be here to help us explain where Medicaid is really wanting to, in the state of North Carolina, make a difference in how we address healthcare disparities. So there's definitely a more increased effort in reporting and tracking quality management and quality improvement. And just the fact that we're integrating the behavioral health and IDD plans in with our state Medicaid move to managed care, and also the enhanced payment initiatives for health equity. Also, as we know, there are many, many groups across our state that are starting to really focus efforts. And one of the things that I know this group has been really proud of is the fact that both NCHA and the Medical Society are working together and also trying to stay engaged with many of these other groups, KB Reynolds, Duke-Margolis, commercial payers, the state, other research organizations, to make sure that we're all rowing in the same direction and that we can combine our efforts to make a really big difference instead of each trying to compete with each other to try and make individual differences. So in summary, what we really noticed is that there's increased requirements to submit the raw data fields. There's an increased focus on data stratification to highlight disparities within individual healthcare organizations. There's an increased production of dashboards, both within healthcare entities and across the state and nationally, to understand where health disparities exist. There's increased requirements and measurements. And there's an increased commitment and effort from funders and researchers to not only better understand the problem, but also see what we can do to work together to make a difference. And that is demonstrated in those increased alignment and partnerships that you see. So what we're really currently charged with is getting to efficiencies. With all of this energy, how can we make a difference that makes sense without recreating the wheel and having each pair make different requirements, each group ask for different data elements? How can we align these efforts? How can we align data collection? How can we get alignment across payers, both government and commercial payers? I think these are some of the questions that we need to ask, and I'm going to turn it back over to Ruth to get started with introducing the panelists that we put together to try and help answer some of these questions.
Thank you so much, Tatiana. As Tatiana's outlined, the work in this space has been going on for decades, and there are a lot of folks focused on both measures, collection methodology, data definitions. I think our challenge in healthcare in general is we have lots of data, sometimes not as much information, and in many cases, not the knowledge necessary driven from that in order to make a difference. So really want to talk about how do we get from data collection to interventions that actually improve the healthcare of the communities and the people that we're serving. I'm going to introduce our panel of experts today. I'm so very excited to have the opportunity to have this discussion with them. And so first, I would like to introduce the Chief Quality Officer for North Carolina Medicaid, Kelly Crosbie. Kelly is responsible for overseeing all quality improvement and pop health programs aimed at improving health outcomes, promoting health equity, paying for value, and addressing medical and non-medical drivers of care within the state of North Carolina. So Kelly, we're so excited to have you here today. Thank you for taking the time. I specifically know how busy you are right now, and so we really appreciate that you're here. I'd also like to introduce the Director of Health Equity and Human Experience at Novant Health New Hanover Regional Medical Center, Joe Conway. Good morning, Joe. Thanks for joining us today. We're happy to have you. Joe's focus is in providing support to all individuals in achieving their highest level of health in the communities where he works and serves. I'd also like to have us introduce Senior Policy Fellow at the Duke-Margolis Center for Health Policy and founder of Ananya Health Solutions, Aparna Higgins. Aparna's leadership and experience is heavily focused on payment and delivery reform, performance measurement, benefit design, health data analytics, and her research at Duke-Margolis centers on provider and medical product value-based payments and improving care for vulnerable populations. So Aparna, so very happy to have you and your expertise on the panel today. Looking really forward to learning from you this morning. And then finally, we have Chief Data Officer for North Carolina's Department of Health and Human Services, Jessie Tenenbaum. Jessie is responsible for the development and oversight of departmental data governance and strategy to enable data-driven policy for improving the health and well-being of North Carolinians. And Jessie, I understand how hard your job is. One of my responsibilities is I get to lead the data and analytics governance group for Atrium Health, and I've learned more probably in the last year about how hard that work is than I would have ever known. So thank you for taking time out of your very busy schedule and joining us today. Let's all get started, and I'm going to start, and Kelly, I'm going to start with you, if you're okay. And would like the rest of the group to chime in. But we all know there's a lot of data collection going on. For Atrium Health, as an example, we have over 900 quality measures that we're collecting for various entities. And so I'm specifically interested in understanding what data elements do you believe we should be collecting? And how do we best agree on the definition of those elements? And then do you think there would be value in stepping back and reviewing and rethinking our data subsets and our data strategies in order to move this work forward in the state of North Carolina?
That is a super big question. First, thanks for having me. I'm happy to be here. And I'll probably answer part of it because I think I think there's a great panel of folks who have different perspectives on all of this and more expertise, like I'm looking at Jessie. I think for Medicaid, a couple of things I would say. We value the notion that we have a source of truth for our data. And we try to share that source of truth with anyone we ask to look at our data in the same way. So I think that's kind of now that doesn't help when you talk about other payers, but Medicaid has a source of truth for demographic data. So that's race, gender, all the data that we have a source of truth. And so when we look at our data, whether we're looking at utilization, quality measures, the use of diagnostic and procedure codes, even when we look at patient surveys and we try to stratify that data, patient survey data, member experience of care data, provider satisfaction data, we're looking through always the same data that we have. We have a single source of truth for our data. And a lot of our efforts are around improving that single source of truth for our data. And what we do when we ask our plans and we ask our providers to look at measures and stratify them in the same way that we do, we share that source of data with them. That's not us saying like our source of truth is correct, because I think we're doing a lot to ensure that our source of data is fairly complete, knock on wood, but there's everything from the way that the data is entered into the system or collected or reported actually by the patient and not by the worker. So there's a lot of work that needs to be done there. But at least we're trying to kind of keep that vein of a single source of truth of data the same. Now, the issue I think becomes, and we use like OSBM categories for data collection. So we try to look at a federal source of truth for the categories that we collect. But again, that doesn't mean that we align with everyone else. So I think that's an issue. For us, another big source of data, source of truth for data that we're continuing to rely on more and more really is the HIE, because it is a state source of truth. And so again, we're trying to figure out how to look at our data versus the data that's coming into the HIE, because it is a statewide single source of truth. So how can we kind of reconcile our data with the HIE data that we are getting? Like I said, I think that's only like part of the question, and because I think there's a couple of things you're saying, like what data elements should we collect, but also how do we all kind of collect the same thing and I think have a single source of truth. And I think that's really, really hard. But I think what we try to do is have a single source of truth that we share. And it might not be perfect because we all need to make it better. But when we are sorting our measures by race or ethnicity, all of our providers, hopefully, and our health plans have the same source of truth, so they can stratify measures in the same way. Just in terms of the data that we collect too, in terms of the outcome or quality data that we're collecting, we do have a governance process, and there are folks on the phone helping us kind of expand that, because our governance does say, how can we come up with a single source and a small source of things that we want to collect, a small set? And how do we standardize that? Again, through all the layers of our system, to health plans, to providers, so we have a single set. How do we use governance to get to the single set? And I think now we're trying to look at, and how do we align that with other payers? So that didn't get to all of your question, Ruth, but there's a lot of other really, really brilliant folks here on the panel.
Yeah, so I'm gonna go to the next brilliant person and go to Jessie. And Jessie, do you think that there would be value in, stepping back and reviewing and rethinking the data subsets and common definitions? And if so, what would be a process to potentially do that across the state? And maybe if you could do it in the context of the HIE, that might be really helpful.
Sure. So I have to confess, we've partnered more and more with the HIE. I'm not formally part of the HIE, but they've been a great partner, especially through COVID. I do think there's significant value to both figuring out the subset, the common data elements, as people say, CDEs, and the definitions. We went through an exercise toward the beginning of COVID for something that seems relatively straightforward, which is how many beds do we have available in hospitals? And I'm not going to show it now, but I've got this very complicated build of animation that shows, well, you've got a bed, and then some of those are ICU beds, and then some of those are staffed beds, or rather, a superset of those are staffed and licensed and surge, and it just like, you would think a bed is a bed, but there's many different definitions and different people define them differently. So with that as one example, I think it's an important exercise and one that's going to take some serious time and effort, and people all together on a Zoom, you know, with a shared Blackboard, understanding, oh, this is how we define it, this is how you define it. I will say I would very much discourage making up new definitions, that most of the elements out there already have standards for them. NIH is a great resource for this. They have a common data elements repository. There's something called the Phoenix Toolkit, PHENX. That's actually based in North Carolina at RTI, where they have a number of standards for describing different phenotypes and different aspects of research. So not just clinical data, but social determinants and smoking status and demographics. So I've given a talk a number of times where I have a slide that says, friends don't let friends develop new data standards. There's something out there for what you want to do. Pick it. Sorry, I'm in the middle of a thunderstorm here. I get it. Pick a data standard, and if it doesn't quite match your needs, contact the owner of the data standard. They will be delighted to tweak it and modify it to your needs and have it be useful and usable and used by people.
Yeah, thank you for that, Jessie. We're going to talk a little bit more about that a little later, so I'll be calling on you again. Aparna, I have a question for you in this kind of broader context of data and data elements. You know, your research is really around ensuring that, you know, we're moving towards value, addressing vulnerable populations. Do you think that we're collecting the data that matters right now? And if not, where do you think the greatest opportunity is to improve the data that we're collecting?
Well, it's a great question. Well, first of all, thank you for inviting me, and I'm really glad to be here with all of you today. You know, I think maybe I would start at a slightly bigger picture level, which is what are we trying to measure, right? And are we trying to measure the right things before we start having conversations about what data do we collect, and are we collecting the right data, and is it standardized data collection? So I think we have to start with what the goals are for the state of North Carolina, and therefore, how do we measure progress towards those goals? I know we at the Margolis Center are actually involved in work trying to align across payers in terms of, you know, what performance measures are selected. And I think there's an increased interest and focus at the national level in moving towards outcome-based measures, you know, whether it's clinical outcomes, but also patient-reported, you know, outcomes. And we've done some work at the center around this, as well as there's some work happening elsewhere in the country in terms of actual, you know, trying to test implementation of outcome measures. So I think it's important to kind of agree, you know, on a core set of measures. You mentioned earlier, Ruth, about, you know, 900 measures. That's a lot of measures to be tracking. So I think starting with what is a core set that, matches the priorities. So trying to get to a parsimonious set of measures. And then based on that, I think identifying what are the core, you know, important data elements that would allow you to assess or measure things, you know, in a valid and reliable manner. That's where I would start. And a lot of these measures are, standardized measures, right? So they are NQF, National Quality Forum endorsed. So they have specifications. And so I think it's important to the extent possible, and I agree with what Kelly and Jessie said about adhering to existing standards and not trying to create new ones. Because ultimately you want alignment, not just of the measures, but how you're specifying them and what data you're collecting them and how the data elements are defined. Because you want to create data that are comparable and that are useful, that a clinician who wants to use the data for patient care ultimately can rely on it and say, this is reliable information I can use in treating, patients. So that's kind of where I would suggest, starting with the measurement and then working your way to, okay, what data do we need? And then how do we define it in a uniform manner?
Yeah, thanks for your thoughtful response there. I do think understanding, what needles we're trying to move are going to be really important. And so, Joe, I'm going to ask you a question. given that we have all of these disparate data sources, and in some cases, even disparate measures, like I said, we have 900. You're at New Hanover. I'm sure you have as many, if not more, coming at you from a variety of different entities that all have their specific focus or lens through which they're looking. What do you think, with all of this data and analytics, what do you think are actual things that we should be measuring and monitoring to have better outcomes for the patient or for the community member? I mean, what are the things that you, New Hanover, Novant, think are important in this space?
Well, I would agree with my colleagues. And by the way, thank you for inviting me as well. I mean, it's a lot of brain power here. I'm humbled to be in the presence of these individuals. I mean, this is amazing. But I would go back to, especially at the community level, I think when it comes to patient collecting, I can give you examples as far as where our organization has started. And it does start at that engagement with that patient. Are we collecting the data? Are we asking the questions? There has been a little bit of resistance there, not so much even from the patient, but probably more so from our staff not asking these types of questions, or feeling though these questions are embarrassing the patient or embarrassing them, or maybe the patient wouldn't want this question asked. And then where's the appropriate space for that to also take place? So when you start getting into SOGI type questions, sexual orientation, gender identity, that may take place in the exam room, with the nurse or the clinician that's in that space. And I want to be careful with data because from a community standpoint, the collection of the data that we're all doing and stratifying and looking at it and looking for those disparities is one thing. And then there's the lived experience at the patient level. So yeah, there may be a disparity that pops up, but you almost would still need to engage the community to find out and dig into that qualitative data, if you will, that is that more lived experience of that individual, and why those challenges exist and what are those barriers which inevitably are going to cross over into social determinants of health. There's usually other mitigating factors that start weighing into this individual's experience. It's not just at the hospital or the practitioner's office level or anything like that. And I know we're going to get into questions around access and those kinds of things. So there's a lot going on there, but always engage the community around those lived experiences. Your data is only going to be able to tell you so much. It's not going to give you the why, the how, the what, or any of those kinds of things where we often can miss the mark. I mean, we're all busy and we all try to do the best according to what that data is telling us. But if we haven't really dug down and engaged the community, we may be missing something. So I would always come back to that from a practical standpoint. Do the data set, identify what you want to work on, as is already referenced. What's the goal? Where are we trying to go? Do we match other systems? So when it comes to that system sharing, we're all on the same page. But then you're going to have to come back to, okay, I need to go out into the community, start asking some of these questions so that I can get the lived experiences.
Yeah. And, Joe, I think that is such a meaningful comment. We want to go to analytics, and, I talk to people who want to use machine learning, and sometimes we jump to what we believe to be true instead of what is actually true. And I'm going to use a real life experience. We were doing some work in identifying, areas where there was significant disparity, and landed on rates of colorectal screening in our Latinx population across our footprint. And, a whole bunch of folks went to, well, the issue is insurance coverage, right? People are not getting colonoscopy because of insurance coverage. And then we went back and actually looked at the data and had conversations with the patients, and most of them were insured. It was not an insurance coverage issue. It was an access issue. our appointments for colonoscopy did not fit within the life cycle of individuals who are working from the day from 8, till 7 o'clock at night. And we didn't have evening and weekend appointments in order to allow people to fit it into their lives. And so when we actually sat back and listened, using the data to take us on the path, we learned, how to actually address that disparity. So I really appreciate your comments around, in addition to the quantitative and actual data that we're looking at, ensuring that we're looking from a qualitative side on what's actually occurring in the communities that we're serving. And so, Kelly, I saw you shaking your head. So I'm going to build on this question and just ask, as we're thinking about improvement and using data to improve and leading to better outcomes for patients, I'd really love to understand your and the department's thought process around what outcomes are you specifically looking for? Is it, some type of quality or quality of life measure? Is it a lower incidence of disease? Is it, lower cost for the patient? All of the above. I'd really like to understand, if we're saying, let's collect, let's improve, here's what improvement looks like. What does that look like for the state?
Yeah, and we are very, in the best way possible. I think we're somewhat focused on the quadruple aim. If you look at our quality strategy, but I think it's not a bad thing, because our quality strategy talks about better care delivery, and that's very much on member experience, provider access, member access, healthier people and healthier communities. So things that you're mentioning, prevention and the prevalence of disease within our population, but also wellness and prevention, especially for kids, pregnant women, women's health, because again, that's a lot of who we see, but also quality of life for folks with LTSS needs. And then smarter spending, which is where we look at not overall cost, but are we spending things in the right places? Are we avoiding, preventable and avoidable things? But I think, for us, we start with, I think those are the right things, right? We want healthy people and healthy communities. That's our favorite one. But you can't have that without good care delivery and patients feeling like they have access. Their perception of access is matching that is their experience of access. We have access for all. We have engaged providers who are not burnt out, who are willing to work with Medicaid. So I think we're trying to care about different parts of the system. Like most people, we look at traditional HEDIS measures, but I'm still in the universe that thinks those are pretty dang important. I do, especially kids measures in particular with their access to immunizations and well visits. I'm one of those folks that care desperately about those, as well as prenatal and postpartum care for women. I think those are really valuable HEDIS measures, but they're only as valuable, I think, as you all highlighted so far, in that they're indicators that mean you need a deeper look to truly understand. But we've actually spent, besides setting up these very traditional structures, we've also spent a lot of time in the past year looking at other indicators. What's the next level of things we want to look at? So right now, an indicator for us is actually low birth weight for Medicaid children. So we had to develop that is an outcome we want to work towards. And that's actually, I think we were one of the first states that had that as accountability measure for health plans. We're asking you to be accountable for low birth weight because we need to do better, and we need to shorten that gap, close that gap between Black and African-American babies and white babies. So that's for us. We've actually spent the past year looking at maternal morbidity and severe maternal mortality in Medicaid. Really small numbers, but dang, do they matter. And so we would really like to have that be an outcome measure that we add to our contracts over time. We've been looking at opioids, really interesting, because we all look at opioid prescribing measures, right? But we're toying around with, can we have opioid deaths or preventable opioid incidences as a measure that we're actually asking our health plans and Medicaid to be accountable for? In our LTSS population, I think we all struggle a little bit with HCBS measures, right? What does HCBS measures look like? Do you feel like you had opportunity in your care plan? Did you sign your care plan? I think those things are really important, right? Because you talk about agency, but we're spending a lot of time looking at measures of folks feeling like their life has meaning feeling like they're integrated in the community. And that's where we want to go. We want to go there with our tailored plan eligibles, our folks with severe behavioral health issues, our folks with IDD or physical disabilities. We want to know that somehow their medical care made a difference in their life. They actually have a better life. And we spent a lot of time looking at patient-reported outcome measures, which are really hard because a lot of the ones that we looked at for those folks that are really into PROMs, they don't change over time, and it's really hard to find the right question. We're actually toying around with the Burfus measure right now that says, I have more good days than bad. Isn't that a really wonderful thing that we should measure? I have more good days than bad. And of course, I would be remiss to not talk about all the data we're collecting now on food, housing, interpersonal safety, and transportation access, right? So we have all the data that we're collecting now, those screening rates. And I think what we're trying to figure out is, what is the measure? Right? The measure right now is the percentage of screening, which is great, right? Because we're measuring, are folks being asked these questions and are they answering them? And we're also using the data to look at prevalence. But how do we expect our service delivery system to move the needle in this space? So we haven't cracked that nut yet, but I guess I'm just trying to share, like, it's great that we're measuring process. I think some of the process things are quite valuable, but do our members, when you think about who we serve pregnant women, we serve kids through the developmental cycle, we serve people with severe physical or behavioral health disabilities. Do they have good quality of life? Do we have healthy babies? Do we have healthy moms? And do people feel like my care made a difference and my life is good? And the more we focus on all the things that affect healthcare, do our folks feel like their needs are being met, their resource needs are being met? So, and chat, we love, you warm my heart when you're talking about the qualitative data. I have a lot of qualitative evaluators on my team, but it's so true. Like talking to people and gathering that data is huge. So I'd say all that stuff, Ruth, we've got the bones of what we're measuring, but pushing the indicators to the next level. So we're really looking at outcomes, that's where we're headed.
Thanks, Kelly. Jody, I saw that you said there was a question in the chat. Do you want to pose that question to the panelists?
Yes, thank you, Ruth. So this came from Ted Rooney. He said, I think the healthy opportunity measures proposed by DHHS in Medicaid transformation are a great start. I'd love to get the panelists' view on those measures as a part of potential universal starter set.
I guess I can start and say, I think that's a great set of measures. I want to point out that healthy opportunities goes beyond Medicaid. So Medicaid is certainly a huge part of it, but it's beyond that. And we have partners where they're collecting it in the context of just doctors' offices in general, not just in the Medicaid population. And we do see a lot of positive screens for some of these indicators. I'm trying to remember I don't remember what this was, but a discussion I was part of, we discussed the fact that social determinants, social indicators are not fully captured in electronic health records right now because there's no incentive to do so in any structured way. You'll see it mentioned maybe in the notes, but there's no incentive for that. So we need to incentivize collecting that information, documenting those issues. And I think the Medicaid reimbursement and the requirement for screening is one great way to do that. I would love to see other creative ways to think about collecting that. I also want to just throw out one thing before we go on. So we're talking about equity and what's important to collect. Race and ethnicity data is really important to collect and can't be assumed, it turns out. North Carolina has used, I don't know if you've seen, we've got national coverage for the fact that in our vaccination data, we have 90+% of that data captured. You wouldn't think that would be extraordinary, but it is. And we were very, very good at it when we were just using our CVMS, COVID vaccine management system. Once we moved to where we were letting the health systems just send us the data from their electronic health records, our completion rate went down and they said, we just didn't collect that. And thankfully from the highest levels, Secretary Cohen was willing to get on the phone with the CEOs and say, that's not acceptable. So just want to throw that out, that you can't take as a given that that type of data is being collected. And should be.
Yeah, and Jessie, I agree. I mean, I think, Kelly's concept of getting from process to outcomes measures are really good, but there are some very, very minimal data set expectations that we should have, race, ethnicity, kind of sexual orientation, gender identity data, because as we start to look at subsets of populations, if we can't at least align, number one, if we're not collecting on that, we can't we can't look at differences, right? I mean, it's just not there. And when 80% of your data is unreported, it's really hard to make generalized, right, projections onto the overall population. And so I do think incentives always help, but some of those basic data elements I think are really important. And Aparna, I would really love your thoughts kind of in this space. And, are there specific care settings where you think, collecting this data? I know we always focus on the inpatient hospital side. That's where, I've spent and lived a lot of my life. And the reality is there are huge swaths of the population. I haven't been in a hospital in 20, almost 20 years. So are there other places where you think we could be collecting this data from? And, how do we support data collection in those areas?
Sure. Well, I definitely think that there are other settings where we could be collecting these data. And just to add to what was said in terms of the race, ethnicity, gender identity, sexual orientation, I would add language to that, because understanding what the primary language preferences are of a patient is important, just from, it's an access issue, it's a patient sort of compliance issue. It's I think you all understand that. I would maybe encourage us to think about this in the context of the broader context, right? What are we trying to measure? And then in the broader context of this whole healthcare transformation that we're going through. So within that context, I certainly think that, collecting these kinds of data within, primary care setting, for example, could be something that we could focus on. And in fact, incentivizing and states already, going down that pathway of incentivizing that type of data collection, in the provider office, primary care office, for example, I think would be important, because as we start to moving providers more to focus on population health management, addressing disparities and inequity is part of that population health management, and therefore supporting providers in that data collection. That could be things like initially at least paying for collection and reporting, right? Before it sort of becomes ingrained in their systems and they've built processes in place to collect these data. I think providers will need assistance, especially, primary care physicians will need assistance in terms of this data collection and training around, who should be collecting the data, at what points. Is it at registration? Is it in the exam room? There's some data elements that are better collected in the exam room, for example, versus registration. And I know that, I can't remember who, someone alluded to hesitancy earlier, from patients, maybe Joe, it was you, in terms of sharing the data. So I think some of the evidence from prior experience has shown that explaining to them why we're collecting this data, what are we going to do with it to help minimize that level of distrust, I think will be important. So all of these will take time, obviously, because systems and processes need to be in place. But I definitely think as we're focusing more on population health management, engaging primary care physicians practices in the collection of these data will be critical.
Yeah, I absolutely appreciate that. And Joe, I know we talked about a lot so far about, what metrics and then what data sets. I'm wondering if you have any thoughts expanding on what Aparna talked about around common process, and then what supports could we provide, right, from a common process standpoint. And then I will get to, Jessie, your hand is raised. Do you want to go first and then I'll go to Joe?
I can wait till after Joe.
Okay, Joe, do you want to go, and then Jessie will go to you? I apologize, I didn't see it.
I'm curious about what Jessie wants to say.
Joe's like, I want to answer your comment. Are there things that you think that would assist, whether it's training or education, public messaging? I mean, are there things that we could do to help make it easier to reduce some of the resistance in collection of the data in some of these settings?
So in the 21st century, I mean, people are very sensitive about what information they release about themselves. And I think something that we've missed the mark on is explaining to the public why we are collecting this information, what we are going to do with this information, and then also putting infrastructures in place to protect their privacy in the information. We have a huge mandate and regulatory compliance on our side where we've got to do all of these things. But I've seen, at least that hesitancy come from what they hear about other industries. I mean, we're watching the news about, our infrastructure that was being attacked. They're thinking, what about my healthcare? What about my credit card statement? How's the bank protecting? So we are a part of that as well. And we've got to show and indicate to them that we have their best interests at heart to gain that trust, as has already been alluded to. So I think there's a tremendous amount of education, and especially around some populations that experience disparities more than others. So I really think about our Hispanic and Latino population that often are very leery of giving information or are participating in, even clinical trials. I noticed with the COVID-19 vaccines, when they rolled out, I was looking at the demographic data that a lot of, Pfizer and Moderna went after. And while they were able to get a lot of these populations, just in our circle here, folks were very, when we started asking for information for those vaccines to be given, very hesitant again from that community. But they're not the only one. And there's all sorts of narratives around that you can speculate about. Some are true, and if you ask, they'll tell you. So I think that education piece for the public is huge. And then I think the other thing that Tatiana actually hit on in her presentation is, we've been required to collect real data for quite some time. I'm shocked at times when I meet the person that's at the front desk or the person at registrar who says, and I'm uncomfortable asking Mr. Conway, hey, Mr. Conway, I see here that, I just want to confirm your information that's inside the computer. You have listed here that you're African-American. Is that correct? I'll tell you yes. Now, probably I'm biased because I work in healthcare, right? I don't want you guessing, because when I did my 23andMe DNA study, I actually found out that I'm 25% European, Irish. Conway is an Irish last name. Who knew? Right? So I may have changed because of that DNA and say, you know what, can you put down that I'm actually two races? Because it's all about the patient. How do they want to be defined? Right? And so we're coming into this 23andMe, Ancestry.com, and all the other organizations out there, and especially the generations they're much more savvy about who they are and how they want to define themselves. And so I think we need to stand up and pay attention that we need to be sensitive to them all and record the data in our systems the way that individual describes themselves. And I think the other thing, and I'll add this, and I just believe this is going to take off at some point in healthcare. It should already have taken off. Where are we with genetics, right? If these outside companies can do it, and by the way, our lab at our hospital also has this technology, many other healthcare organizations do as well. Pharmacology is greatly tied to some of their outcomes and some of the data around genetics. There are certain drugs that I probably shouldn't be given. I was blown away. I'll give you this personal illustration. Again, personal story. I'm in my doctor's office. He's got me on a high blood pressure medication. He says, Joe, how are you doing with that? I said, oh, no, I'm doing pretty good. He makes this statement, and it literally almost caused tears to come from my eyes, because I'm 51 years old. I'll be 52 on the 20th. Yes, I do take presents if you want to send them to me. But he says to me, he says, Joe, I'm going to change your medication because this medication has better outcomes for African Americans. I almost hit the floor. Because as a health equity director, that's what I want to hear.
Yeah.
And I guarantee you there are other patients that fall in that same line. What is going to be best for me, my body, my chemistry, who I am? And when he said that, I literally jumped off the table and hugged him. He was taken a little back, but the point is that he connected with his patient. And how many other patients are waiting for that kind of experience? And then they will give us the trust that we expect out of them. But you have to earn that. And he earned my trust that day. So I know that's a long explanation, but just want to bring it back to that. Yeah.
Yeah. And perfect example of somebody asking you the question of how do you identify yourself so that they could use that information to actually impact the care, right? Like if we hadn't asked that question, he wouldn't have been able to say, and this is a medication that's better for you. So, I mean, I just a full circle, you know, we think about it at the aggregate population level, right? And perhaps it's outcomes rates for, you know, groups of individuals, but it also does impact, you know, how we engage and treat individuals at a personal level, right? And so great point, Joe. Thank you so much. And thanks for sharing your personal story. And oh, by the way, happy birthday. But I know that Jessie had her hand raised, so I'm going to go back to her. And Jessie would love the comments that you wanted to make and building off of Joe's comments.
Yeah, building off of both Joe's and Aparna's, that we talk a lot about moving forward at the speed of trust. That we really need, you know, we're asking for personal information and we can understand why people may be uneasy. And so building those trusting relationships to make people feel comfortable giving the information. There's also this concept, when I first met Kelly and we were talking about quality, I realized we were talking about totally different things. She talks about quality of care and I'm talking about quality of data. And so data quality, we have this notion of fit for use. You can have data that is completely 100% appropriate for clinical care, and the care you're giving that may be read by a human being, that may be jotted down on paper, that is not at all fit for the use of data mining and understanding our populations and doing population health studies. And so I think that's an important distinction to make and to get the providers and their partners to understand for documentation purposes that the most important thing is the patient in front of them and keeping them healthy. But that if they can do, you know, take the split second it takes to structure something, to pull a drop down, as opposed to writing something in notes, that's going to help us to leverage, move toward what we describe as a learning health system of learning from every day when we go to the doctor, we're collecting data that could be leveraged to improve all of our outcomes. There are a couple other things in there, but I think, one thing about the race thing is that being able to indicate more than one race is great. And we're making strides in precision medicine and using genomics for pharmacogenomics and other areas. But I hate it. It drives me crazy when I see just multiracial. Which races? Someday when they're saying a medicine that's good for African American and Asian, it's not going to help if you just say multiracial. So yeah. Thank you for that.
Very, very, very good point. Again, this idea and concept of what are the definitions of what we want to collect so that we could get to the outcome that we're trying to achieve. And it is a stepwise process. And so I'm going to ask a question and whoever would like to go first would be great. I've had the wonderful opportunity of participating in a number of collaborative experiences since I've been in North Carolina. And I'm just wondering if you all have, or anybody wants to take a stab at what approach might make most sense for, us as a state to developing a clear and consistent path around, health equity and other data. Should we have some type of coalition or task force similar to what we've done with Healthy North Carolina 2030? Do we embed it in an existing resource or platform? I'd be really open to, if you had your dream of how we would move this forward, what do you think the best way to come up with a process to get us to data collection in a meaningful way that would then help us drive outcomes? So anybody want to raise their hand or just start speaking to go first, or I'll call on you?
I'll say include the HIE and stakeholders. And stakeholders is everything from the patients to the providers, to the payers, to the researchers, to the, I'm sure I'm missing many, data scientists who might use it, informatics experts who are experts in data standards, include all of them in the discussion, and definitely the HIE, which, as you pointed out, is our statewide, mostly statewide, one area. I would love to see North Carolina have an all payers database. That's actually, just noticed, that's on my to-do list to look into that someday when I've got a spare moment. I think some other states have succeeded in that. I would love to see us move in that direction.
Yeah. Well, I would agree. I think, using a collaborative approach and engaging the different stakeholders will be key. It's one thing to say, well, everybody should collect race and ethnicity data and then have everybody collect it 15 different ways, right? You want to avoid that. So having a collaborative approach and a clear process with milestones, laid out in terms of, what you want to collect, what level of completeness you want to get, what level of, how do you assess accuracy of the data, because I know that's always a concern as well. I think all that, making a sort of a concerted statewide effort that involves all the different stakeholders, I think will really help in terms of getting structured, reliable data over the long run that can be used for the various purposes that you would want to use it for. I think the other thing to keep in mind, we talked about this earlier, and I completely agree. I want to underscore something Joe said about this, we talked about source of truth, is patient self-report is the gold standard. So as you think about this collaborative process, how do you get to that patient self-report, in a much more consistent and complete manner, I think will be important. And then keeping an eye on what's happening federally, right? Because you want to make sure that in some ways you want to, obviously North Carolina has been leading in a variety of areas, and the rest of the country is looking at North Carolina as an example in many ways, but also keeping an eye on what's happening federally and trying to align, with some of the national efforts, I think will also be helpful.
Kelly, I hate to put you on the spot. Do you have any, I think that it makes sense, right? We're already starting down the path in a number of areas. Mm-hmm. We have a strong HIE infrastructure, right? We've got the NCDHS engaged, Medicaid engaged. I think we've got really, really smart people at Duke-Margolis and other, kind of learning health system organizations across the state. Do you have any ideas, again, on how do we start to think about prioritization and a pathway to, consistency? Because if we have 25 different entities going in 25 different directions, we wake up, 5 years from now and we're in the same place we are now, where there's pockets of brilliance happening everywhere, but they're all occurring disjointed. And so I was wondering if you had any ideas of this is what it would look like if from the department standpoint, from Medicaid standpoint, if this was being done well.
Yeah, and I'd probably just emphasize a lot of things that other folks said, but honestly, when you ask that question, I feel really sort of struck, and I'm gonna sort of credit Joseph for still being struck by something he said early on. I really feel like there's a conversation to be had with the people whose data we are collecting. I'm still a little bit hung up on that. Are we talking about our data, which I think is fair, right? Like, we have health insurance. We're blessed to have health insurance, and someone's collecting our data. Let's talk about that. Let's talk about what data elements people want to know about me and what the best place is for me to answer those questions. But I think we should really do that with our members too. So just speaking from Medicaid, that better engagement with our members to talk about, okay, let's just talk race and ethnicity and SOGI data. Is that what we're talking about right now? Is that the demographic data that we care about? Why do we need that data? What are the ways we should collect it? How do we train the people that are collecting it? How do we ask in the same way? And I'm so struck by Joseph, your comments about where we collect the data, because where we collect the data now at Medicaid is at the DSS office. And we just immediately, probably 5 things popped into our head around why that's not the best place to collect data. No disrespect to our DSS folks. They do a wonderful job, but there's just a fraught with meaning experience. And that's probably not the moment to be asking about race and SOGI and safety and other data. It's just a fraught environment. It just is. So that is so not answering your question, Ruth. But I just it's very easy to say, hey, Aparna, you guys do a fantastic job of convening people. Let's be real clear. You convene people. You convene payers. You convene providers. You convene members, and you say, we're talking, what demographic data are we talking about? What's the gold standard for categories? And how do we who are the experts, right? Because it's not me. Who are the experts on what tool we use to collect that data and how we ask the questions and who we train to ask the questions? And then how the heck do we ensure that throughout the entire convening process that we have members, because it's their data that we're talking about. So how are they're weighing in on all of this?
Yeah.
But I suspect that the way we ask it now, we're all well-meaning, but we're all asking it. It's not just that we're collecting it in different ways repeatedly and documenting it in totally different places. And God, like, how the heck do we even rectify it all? But like, it's like people that we're like asking repeatedly the same things, and maybe not always in the best way, not even offering them the categories that make sense to how they perceive themselves. So just like that part of like, what, back to what Aparna said, what do we want to collect? What are the right categories? How do we explain it to members? What's the right culturally sensitive and appropriate way and space to ask those questions? And then the mechanics, how do we use a common tool and collect it in a common source or place like the HIE, something like that. So.
Thank you. Aparna.
Yeah, I just wanted, I really like the way, Kelly talked about getting the perspective of the people that we're collecting the data from, right? And Joe, I think rightfully you put that at the center. We talk a lot about having a person-centered healthcare system. Well, let's start with the person and talk to them and get their perspective. I think that's really critical here. So I just wanted to underscore that aspect in terms of engaging the person in all of this. And then designing a system that would be the least burdensome, right? We talk a lot about provider burden, but there's actually a lot of patient burden and family caregiver burden. So I think as we think about data collection and where we collect and how much we collect, and not duplicating the same data elements everywhere and asking them the same questions, let's be thoughtful about the process we design so it could be done efficiently in the least burdensome way, both to providers and patients and their families.
And if we're using similar tools and definitions, it's so much easier to share it across where appropriate entities, right? It's when I'm collecting a data set in a specific way that doesn't align with everyone else, it makes it almost impossible for me to share it back with Kelly because it doesn't match up. Or if I do share it back with Kelly, it takes 14 IT people and a whole bunch of data scientists to figure out how to map, right? Which pretty much makes it impossible. I'm gonna Tim Gallagher has a question for the group. So before I go on to my next questions, I'm gonna ask this question. It's a really good question. And so he's asking, we've talked a lot about individuals who have quote unquote insurance and how their data is collected. And his question really is, who represents the uninsured data in the aggregate? So at the population level, some of the NCHA members collect information on uninsured patients in their emergency rooms. We have free clinics and FQHCs and other entities that serve patients in primary care settings that are representing the uninsured. And so his specific question is, and I don't know the answer to this, maybe Kelly, you or Jessie, does the CMO of DHHS have consent to report, collect, encounter level data on uninsured patients? Or, and I see Joe, I guess you have your hand raised, but can we answer Tim's question? Does anyone know the answer to that? Because I don't.
To the extent I know, there are certain reportable things that must be reported to DHHS. And so certainly those, not just on uninsured, but on everyone. But beyond that, I don't think there's any duty to report or presumed or implied consent to give the encounter data to DHHS.
But that's a significant portion of the population of the communities we serve, right? And may be even more significant in some of the underrepresented populations. So I mean, really good point, Tim, right? Like can't leave that group of folks out of the thought processes we're thinking about addressing disparities across North Carolina. And Joe, you had your hand raised, so I'm going to go back to you and allow you to answer.
Yeah, my comment was in reference to something earlier, but to Tim's point, that is a powerful question that I think strongly needs to be considered. And even to the point that you made as far as where disparities may exist, that is a group, uninsured folks, that may be struggling. I mean, think about preventative care. Think about, someone that's monitoring them. That data, my opinion, I think it definitely needs to be collected for sure. And it does need to go to NCDHHS or whatever entity, our government, deems necessary. But the reason it needs to be closely monitored, oftentimes, those are the same folks that are that particular population that are driving, your ED visits, right? They're high ED utilizers. And sometimes that could be managed by a primary care physician, but they don't know that. And there are different models of those primary care physicians that they may not even be aware of, such as these, I've heard of these, for lack of a better way of expressing them, like these gym type memberships where you just pay $35 or $40 a month and you get certain things from that physician while you're in their care. So I think that particular group, we really do need to monitor. That'll also help in designing systems, healthcare coverage, if we ever decide to expand Medicaid in this state, that will help us define, what's their experience? What do they need? What's the low-hanging fruit? How do we manage disease within that particular population? So there's a lot of information, if we're not collecting that we're really missing out on. So Tim, great question. I don't know the answer to it, but man, what a great opportunity.
So Ruth, this is Tatiana. I hate to butt in, but knowing just the tiniest bit about some of those networks of care for the uninsured that NCHA works with hospitals and others on, I do know that those data elements are part of the data set that is collected for working with those networks of care for the uninsured. I've actually pinged back a couple of folks to see if we're tracking health disparities across those networks of care for the uninsured, to see, what other outreach is being done and what we can learn from those.
Yeah, and Jessie, great point. I do think there are individuals that are, see Medicaid patients as well as uninsured patients. Again, I think the question is, what encounter data do we collect? What encounter data should we collect? And then, how is it collecting? And then how is it used? And Kelly apologized, but had to drop off. So now we have our 3 remaining folks on the hot seat. And Jessie, would love for you to perhaps expand on, do you think are we collecting that data? You said maybe we're collecting it, but we're not analyzing it like we do on the Medicaid population.
Yeah, well, there's a distinction to be made between clinical data, things like what is your A1C lab value, and encounter data. So like this person went in for a diabetes well checkup or something like that. Claims data for Medicaid comes to DHHS. Clinical data for Medicaid and for all providers who are participating in the HIE, which is a pretty good chunk across North Carolina, go to the HIE. The HIE has an advisory board, and it has various people requesting to use the data for research, and it has a group, I forget what it's called, but sort of a group to evaluate those requests. So I haven't heard of anyone doing those analyses, but it wouldn't surprise me if that is taking place with appropriate de-identification, security, privacy, all of that.
Thanks for that feedback. I'm going to keep us going along. And I know we talked a little bit about who should be at the table. And Joe, you brought up the fact that we should actually have our patients at the table from a stakeholder standpoint. And I know we talked about, and Aparna, this might be a good one for you, since the Margolis Center does a lot of convening. We automatically think about the payers, both in, commercial, independent, as well as, our Medicaid system. Joe's comment on, having the patients at the table, we probably need some providers at the table. Are there any major groups that, we wouldn't normally think of immediately that you think should be included as part of the process as we start to think about building a holistic system to both collect this data in a standardized way, but then use it in order to improve outcomes?
I would also add employers to the list. I know we haven't talked about them explicitly, but I think, we've covered most of the major groups, but I would add employers to the list. Not all employers are, at the ready in terms of helping with the data collection themselves, right? Again, it's a sensitive issue, and for various reasons, they may not want to be involved directly in the collecting race, ethnicity, language data, but I think they can, for example, require it of their plans, put it into their contracts with health plans to say, well, you'll collect these data or work with providers to collect these data. So I think having employers at the table, especially for the commercial population, will be important in addition to the other groups that we've discussed.
That's a really, really good point. Thanks for bringing that. Joe, Jessie, are there other groups that you think of that would be really helpful to have at the table? If we thought about a process to bring groups together, stakeholders together to talk about not just what we collect, but what the process for collection is.
I think the usual suspects. This is an area where I feel like we're finally aware of the importance of involving the people of whom the data is being collected and asked. And I think employers is also a good point. And then the usual guys, gals.
Awesome. So if you had your perfect world, and any of you can choose to answer this correctly, how do you realistically think that we could start to get everyone on the same page, using the same approach, collecting the same data sets, putting it all in the same place, and ensure everyone that needs access to use it to improve the care we're delivering has access? Are there any entities, states, other places that you think that is doing this well? And if so, would love to hear about any ideas that you have. And if not, do you have a thought process on what a process might be for North Carolina to start thinking about doing this? And anybody can answer.
I don't know of specific states doing it, but there is definitely a model for this type of work with HL7, which is the standards organization responsible for fire, and HL7 version 2 that's commonly in use. And for that matter, LOINC and ICD-10, and there are processes and best practice out there for identifying standards, not creating standards, mind you, but identifying, narrowing down standards. I think a lot of times it comes down to some small group putting out a straw man and saying, here's what we propose, and then let the stakeholders weigh in and say that won't work for us because X, and then you iterate. And then there's a whole balloting process and getting real buy-in that says, yes, we come together, we support this, we think this is the way to go, and we agree to do it.
Yeah. I would add to that, I think, yes, definitely there's other areas where like HL7 and LOINC and other things that were mentioned. There's also nationally an effort called Project Gravity that is working on establishing standards for social risk factor data and so forth. I would say maybe there are two levels at which I almost feel like this conversation needs to happen. One is kind of like at a strategy level, right? Why this is important, what are we seeking to achieve? What do we plan, how do we plan to use the data, and kind of really making the case. I think everybody gets it, but, maybe clearly communicating the so what out of this. Everybody talks, I think we all talk, I should say, about, burden. I've been trying to reframe it more as effort, and, what are we getting out of the effort that we're putting into collecting this data? So I feel like there's kind of coming to an agreement on that piece, and then working on, okay, now we've sort of agreed this is important and here's why we're doing it. what are the standards, how do we collect it? What are the best places to collect it? How do we ensure that the patient voice is reflected? And almost like a standard setting process that, can follow other standard setting process that have been established, nationally. The one state that I will point to and that has been quite active in terms of collecting race ethnicity data for quite some time is Oregon. So, as you're thinking about how you want to approach this in North Carolina, I would maybe suggest having some conversations with Oregon.
Yeah, I don't have much to add to that. Aparna, you nailed it. And I love the approach of starting out with a goal in mind first and then beginning to define, collection, where is it going to be kept, all those kinds of things. So that was perfectly stated.
Yeah, and I love the idea of the strategy. Why is it that we're doing this? Like, what is the North Star? I think a lot of times when we don't say we're doing this because, right, then it does seem like it's a burden. When we say we're doing this to address disparities in these populations to improve health, and here's the measure, right? Here's what our measure of success is. It makes it real to the individuals that are doing it. And there's still an effort, but it's not just one more thing we're collecting, right? So Aparna, I really do think how we have the discussion and how we define what is the strategic purpose and then what is the practical process is really, really important. So we have.
Sorry, can I just, really one quick thing on that. And I think that's where the kind of the personal story that Joe shared earlier with his own experience at the physician office and the blood pressure medication is, I think that's the kind of story that will resonate. And we talk a lot about getting buy-in, not suggesting Joe shares personal story with everybody outside of this panel, but I'm saying generally speaking, I think really stories resonate a lot. And I think, we talked earlier about, and Joe emphasized not just the structured data, but the stories are so important. I think that's got to be part of this process.
Very point well taken, right? And I think the why for each individual person is a little different. And if we can tell a lot of stories, we can connect with a lot of people. Yep. Ted mentioned, and I have not, so I'm going to do some research when I get off the meeting today, about a community information exchange movement led by San Diego that is spreading across the country, focusing on equity. Are any of you aware of that particular? Yeah, see, that's why we need people like you, Ted, as part of the process and more stakeholders to bring forward some of these really good ideas. So we'll absolutely take a look into that. So and again, I'm going to ask one more question, and if anyone from the audience has other ideas, we would love to take those from you. If we were doing this process and I'm going to have each of you kind of address what you think, what do you think a realistic timeline is to, do planning, right? Including all of the various stakeholders we've talked about, developing what those true North Star measures of success are and putting the stories together as to why, and then implementation. I'd be really interested in, some realistic timelines that you've seen as others have, tried to pull these kind of processes together, both for planning, development, and implementation. And Jessie, we'll start with you. You've done a lot of work in this space with the state and the HIE. What's realistic for North Carolina?
I think realistic to have something, and it's going to be iterative, but 18 months I think is very realistic. Last night I was looking at the questions and reflecting and thought 12 months, let's throw it on the gauntlet. But if we want to be realistic, let's say 18 months, I really think, we've identified the issue, we've identified some paths forward. This could be done.
Joe, what do you think?
I definitely agree with that. And 18 months is very realistic. I was thinking 18 to 24 months. And I'm going to look at it from, let's say, my organization standpoint. So let's say the plan development has happened and we're we're really on the implementation side. So the information is coming down to us, what's New Hanover, what's Novant going to do to answer the call, right? So the organizations would also need some time either for infrastructures to be put in place and the like. But I definitely agree with the 18 months time schedule. I think that's plenty of time. We've known a lot of this for a long time. And we've kind of danced with it and we've talked about it. And some of us have even implemented processes to address certain things within it. So I think we don't want to take too much more time than probably the 18 to 24 month time range.
Yeah, I was going to say 2 years. But 18 months would be great, just based on, my prior experience doing not exactly this work, similar work. It's taken a 2-year time frame. So, I think 18 months sounds, if it's doable, I think would be even better.
Well, I'm going to give the audience a few more minutes for questions. If there are any other questions, I want to thank you all for the very engaging discussion that we've had. I'm now even more excited than I was when the planning group got together and said, we have all these really smart people in the state. What should we talk about? And we decided that, beginning to think about using real data, and improving outcomes for the state of North Carolina and the people who live, work and play in our communities was really important. And I'm now even more energized. I'm going to challenge our NCMS and NCHA folks to help us think about what a process would be to get the right stakeholders around the table. I think if we say 18 months to 2 years is a realistic time frame, the sooner we start the work, the sooner we can get to, using some of this information to actually impact the outcomes that we think are important. So I don't know, Jody, if you, or I don't know if Kristen is on, if you have any comments, but I want to thank our panelists today. We'll let Kelly know we thank her too, and Joe, Aparna, Jessie, and Tatiana for sharing your expertise with us today. And thank all of the participants for joining and participating in this 2021 third quarter Pop Health Collaborative meeting. We appreciate your time and engagement. We'd also like to know if you would have any interest in, as we start to think about how we might bring stakeholders together to have these discussions. If you have any specific interest in participating, we would definitely like to know that. We are also in the process for preparing for our sessions for 2022. We would welcome any feedback on topics or discussions that might be of interest to all of you. We were gathering last night as we were preparing for today, and we were talking about workforce might be a really interesting topic to talk about in the first quarter of next year, but would love any feedback that you might have. And please feel free to reach out to either the NCMS or NCHA staff with any ideas that you might have. We would really appreciate that.
Ruth?
Yes, ma'am.
Yeah, this is Jody. I just did want to also mention, and Tatiana put this in the chat function before anybody leaves. Is a link for that community information exchange. So if you don't have the chat function open, please open it and you can download that or save that information for future reference.
Thank you,
Tatiana.
Thank you, Tatiana. I don't know how to put stuff like that in the chat function, so we thank Tatiana. If there are no other questions, we would like to thank you for your time today, and I wish all of you a wonderful remainder of your week. Please stay healthy and take care of yourself.
Well, thank you so much. I really enjoyed the discussion today.
Thank you, guys.
Thank you. Appreciate it.
Bye.
Bye-bye now.